Right. They put me on the lavalier thing. Hopefully it works. Thank you, Stacy. So Stacy and I have known each other for a while, and we're working together on various aspects of the California Future Health Workforce Commission, which is funded by 5 different foundations, all based in California, intended to develop recommendations to deliver to our new governor, whoever that may be, about policies that need to go into place to make sure that our health workforce is ready for the future. We're aiming 2030 is the notional benchmark that we're using in that. So we get to see each other at those meetings, and then I visit OSHPD periodically, which is what I call her office. I call that agency OSHPD. I did my dissertation with OSHPD data, so I have known and loved that agency for many, many years. So I'm going to talk about nursing shortages, surpluses, and skills, and I'm really doing a little bit of a hodgepodge of a few different studies. And I think most of my slides have what study, and I can point anybody to the full reports and all of that if you want to be a glutton for punishment and read hundreds of tables. So healthcare system challenges. So I just came back from an international health workforce meeting that was, it's a collaborative group that's been meeting for about 20 years now of representatives of people from English-speaking countries around the world. And it's amazing that even with different countries' financing structures and everything, we have in common. But the U.S. is a little bit more dysfunctional than some of the other countries. We've got huge amounts of fragmentation in our healthcare system, right? We have public systems, private systems. We've got discontinuities between medical groups and hospitals and long-term care and all of. And then everybody's got their different insurance plans, and even many insurers offer multiple different plans. So if you're on, Blue Cross, you might not be on the same type of Blue Cross plan as your next door neighbor who's on Blue Cross. There's a lot of fragmentation in our system. And we have a lot of healthcare disparities. And that was one thing where I have to say the delegates from the other countries don't really fully appreciate the degree to which we have disparities, although we are not alone. We were hearing about the disparities in the UK, disparities especially for Canada between rural and urban areas. In New Zealand, it was between the Maori and the rest of the population. So disparities are not just a U.S. thing, although one might argue that ours are a little bit worse than some of these other countries because of the way our insurance system is structured. Like we don't really have one. All those other countries have at least something resembling universal coverage, but they are still not perfect. That is not enough. We and all of these other countries, we have an aging and sicker population. And that's just simply the baby boomer demographic is large and getting older. And that is a worldwide phenomenon. That is not just the United States. Japan and Korea, I think at this point, have the oldest populations in the world. So they're kind of a little ahead of us on dealing with this. But it's hitting most EU countries. It's hitting most English-speaking countries. It's a little slower for Latin America and for China, but it's coming to them too. We have primary care shortages. And again, this is a very international thing that you hear in many countries. And I'll talk a little bit about that, but we recently did some research with Janet Kaufman, my collaborator leading that study, that I measured really how bad the primary care situation is in California and how much worse it's probably going to get over the next 20 years. It's very hard to get a primary care provider. Even if you have good health insurance, you might have a hard time accessing a primary care provider. And the numbers of graduates, especially from medical school primary care residencies, are not enough to fill the gap. The good news is nurse practitioners and physician assistants are growing rapidly enough to fill the gap, but there are regulatory barriers that we need to deal with to really maximize their potential. And then we have high costs. No other country in the world spends as much as we do. And we spend about probably 30% more than the next most expensive country, and we are not 30% healthier. So I will argue that nursing is the key to solving these problems. And there are multiple reasons I believe that nursing is central to this. First, nursing is the largest licensed healthcare profession in the United States and in the world. By far. There are 4 times as many nurses as physicians. So people think about health policy change, and they tend to think, oh, the American Medical Association has a statement about this. And it's like, yeah, but there are 4 times as many nurses. Now, the nursing profession itself is fragmented. in many ways. And also, the nursing profession has a long history of basically being perceived as the handmaidens of doctors. But there are 4 times as many of them. They are everywhere. They are in every practice setting. They're with every kind of population. They provide care in long-term care, acute care, primary care, home care. They're everywhere. And therefore, they are absolutely essential to solving all of these problems. Nursing is known from a whole variety of different studies and just logic to have a big relationship with patient quality of care, patient satisfaction, and is very closely tied with some of the evidence around different kinds of value-based payment structures that are trying to link the way that healthcare providers get paid, the quality of the care that they provide. Those providers that are successful in those programs are finding that they have to have good nursing care in that, not only for kind of your classic acute care nursing, but also care coordination, patient education, helping patients transition from the hospital to the home, or to hospital to rehab, to nursing home, to home, or to whatever those pathways may be. Nursing education is fundamentally whole person focused. So when you look at the International Council of Nurses definition of what nursing is as a profession, it emphasizes language around helping people attain optimal health and not cure disease. And not, it's not about curing disease. It's about helping people attain optimal health, whatever that optimum may be for that person. So palliative care and hospice care originally really grew out of nursing. That nursing was one of the first professions in the licensed healthcare profession world to say, there are times where we are not going to cure the person, but we can do a lot to make their health better and to make their psychological well-being better, which is part of your health. And so nursing really has a leading role in thinking about the individual as a whole person. It's really inherent to nursing education and essential to, I think, how our healthcare system needs to evolve. And they have a very generalist education. So I have a colleague at University of North Carolina, Erin Freyer, who says nurses are the stem cell of the health workforce. You can kind of put them anywhere, and their generalized education, their very strong clinical basic education, will adapt them into whatever setting they're working in. So you can take a nurse with the same basic education and put them into a home health setting, and it will apply to that home health setting. You can put them in an acute care ICU unit, and they will be able to adapt to that ICU unit. So the nursing education is very generalized in a lot of ways, and that sometimes can be frustrating because you have to adapt into the setting that you're in, but you can adapt to any setting. Whereas a lot of the other professions, respiratory therapy is a great profession, but you're very specific to the pulmonary system. So it's not the same kind of generalized education that, say, nursing has. And medicine, at its core, has some generalization to it, but doctors specialize very rapidly, whereas nurses do not specialize as early in their careers. So there's a lot of opportunity. So hopefully I've convinced you that nursing is really important. So we've been seeing, these are all headlines from the past year or two about nursing shortages. And for those of us who've been studying this and kind of just even being vaguely paying attention to this for a while, it's like, wait, didn't we hear this 15 years ago? So 15 years ago, we were hearing reports of nursing shortages. And then about 10 years ago, we started seeing reports that new nursing graduates couldn't find jobs. So we had a surplus of nurses. And now we're starting to see shortage stories again. And so those of us who've been studying this for a long time go, oh, here we go again. And, and so my interest is, okay, why is this coming back? Why are there perceptions of this? Because I'm going to show you some data that don't really align with this narrative. And I understand that journalists want to tell story, if it bleeds, it leads. So there is a tendency among journalism to highlight crises or perceived crises, even if the data don't always support them. But I also do think that there's an element of truth here. So I've been trying to figure out what is going on. So some historical context, really since World War II, which is pretty much when we started having data on this, we've had cycles of nursing shortage and surplus. And these have cropped up in the data over and over again. And the first economist to ever study this was a guy named Donald Yett. He's in the faculty at USC. He might be retired by now. But his dissertation was on this in 1970. And he basically applied labor economics models to studying the nursing labor force. So kind of more recent history was there was a perceived shortage of nurses from about roughly 1988 to 1992. And then starting in the mid-1990s, there was a perception of a surplus of nurses. That period of time coincided with the rapid growth of managed care programs. As managed care grew, hospitalization rates declined because the idea was keep people out of the hospital, treat them in outpatient settings more to save money. And so if you don't have as many patients in the hospital, you don't need as many nurses in the hospital. And nurses reported that they were having a hard time finding work. If you looked at inflation-adjusted wages over that period, they actually declined a little bit. That was the first time you could ever see that in the data. And so there were legitimate concerns about what was happening in nursing. There were some expert groups over that period of time that also recommended that nursing schools close because they believed that this was going to be the future, that nobody would be in the hospital in the future if we could avoid it, and therefore nursing was just going to be much, much less in demand, and we didn't need to graduate nearly as many as we did. They were wrong. Because then what happened was around 1998, you started seeing reports about nursing shortages. And by 2004, it was like red alarms everywhere about the nursing shortage. It was the most severe we'd experienced. The projections were saying we were going to be more than 1 million nurses short. And that went on for 10 years. So that was also the longest shortage that we'd experienced. And then came the market crash around 2008. And all of a sudden, people perceived a surplus, and nurses weren't finding jobs. And now what's going on? Now we're beginning to go back into the are we in a shortage realm. So that's kind of your brief history just for the past like 20, 25 years. So why does it always seem like we have these shortages of nurses? Well, I mean, okay, so I'll start with my cynical and then I'll start with my economist. So the cynical is that interest groups like to have shortages. It gets you attention. Gets money for nursing and medical schools. There is no surprise about why the American Association of Medical Colleges always publishes forecasts that show shortages of doctors. They have never published a forecast that has said that there is an adequate number of any type of doctor, ever. Because their business model is if there's a shortage, then Congress will give them more money for medical residencies and for medical schools. And they are, after all, the American Association of Medical Colleges. So that's my cynic, right? So the same thing would apply for, nursing groups. If there's a shortage, there's more money, there's more education money, there might be pay raises, there might be advantages for people thinking there's a shortage. Okay, but there is some truth to this. So setting aside the cynicism, we've got real reasons to believe there could be a nursing shortage. The baby boomer population is getting older and they are demanding more care. So we can just start with that. That is a trend that is going to continue for like 20 more years, 30 more years. And life expectancy is longer, so I don't know, maybe it's 40 more years, right? We've got smaller subsequent generations. So you've got the baby bust following the baby boom, so you've got fewer people to take care of the baby boomers. Essentially, the baby boom nurses are going to retire right when they all need to have their knees replaced. So who's going to help them with that? You've got residency funding in medicine hasn't increased. And for nursing is different. Nursing education has increased a lot. And I'll show you some data on that. We've also had immigration. We've had concerns about immigration. So I think under the current administration, there is real reason to believe that it's going to be harder for nurses and physicians to immigrate to the U.S. to work. And that may affect our supply of providers. And then also in this, we've got, to the extent that it's holding in place, the Affordable Care Act still exists. And so we have more people in health insurance plans. And when people have health insurance, they demand more care. So as long as the ACA does not get repealed, and right now it's not looking very promising for a repeal, then we will probably maintain that additional increased demand. So how do we know when there's a shortage? One of the first projects I did at UCSF was with Kevin Grumbach and Jean Ann Seago and Janet Kaufman, who I work with all of them still, except Jean Ann retired, so we just have lunch. And how do we know there's a shortage? So we looked at these data that had all these different things. First, you get all the press releases, right? All the press and the stories in the news. But then you can also survey hospitals and say, do you think you have a nursing shortage? You can look at their vacancy rate data. You can look at the time it takes for them to recruit new nurses. And then you can do really fancy econometric models, and it turns out that all of these produce highly correlated results. So to some extent, it almost doesn't matter which measure you pick. If the measures are showing a tendency towards shortage, there probably is a shortage brewing. Now, can we measure exactly how many? That's tricky, but at least it gives us a trend. Now, thinking about the age distribution of working RNs, this also can give you a hint about what might be coming in the future. And this is a messy chart, so, and I promised folks that I would slap on the white thing. So I'm going to slap on this one instead of that one. I'll give that one a turn later. So this blue line here that's got kind of these triangles on it is the age distribution of nurses in California from the Board of Registered Nursing Surveys in 1997. So in 1997, the largest population of nurses in California were between 40 and 49 years old. So they did their next survey in 2004. That was when the legislature said they had to start collecting data every 2 years. So they did a survey in 2004, and not surprisingly, now the oldest population is 50 to 54. So basically all these nurses got older, right? And you've got, look at what a small share of the nursing workforce is in these younger age groups. Then you go out to 2008, and you've still got this peak here. Now, during this 2004 to 2008, we were going into panic mode about the shortage. So nursing education in California started growing. Nursing schools, deans and directors in California need huge commendation. They more than doubled the number of graduates from nursing schools in California over about a 7-year period. So huge growth in our nursing programs. So by the time you get to 2016, look at this orange line. Look how nice and flat our age distribution is. Because we've had all of these new graduates come into these younger age groups. And so now our age distribution is nice and flat. So as you think about these people retiring out here, we've got about the right number of people to replace them coming in, which bodes well. But you can see why people were panicked here with the age distribution of our workforce and the lack of new people coming in. Okay, another messy chart. I love messy charts. I promised I'd slap on this one. So these are just the employment rates by age group. And so this is 65 and up. No surprise. Now, there are a lot of nurses who maintain their licenses. We found nurses, I think the oldest one I found in the database this year when we did our survey was 102. I'm not kidding you. She still has a license. I don't know if she's working, he or she. I mean, I'm assuming it's probably a she. But yeah, I don't know if he or she is working. I don't know if they were randomly selected for our survey. We'll see. But I mean, people keep their licenses often as a point of pride, right? It's just, I've been a nurse my whole life, and I don't know what they're doing for their continuing education requirements, but they're doing something. But of those and a lot let their licenses expire, right? So of those who have their licenses who are 65 and older, about half of them say they're working in nursing. Now, some of them are working part-time. Some of them say they do a flu shot clinic at the senior center, 3 times a year. And yeah, and if they get paid for it, that's working. It counts. Some of them are actually working the hospital floors and still doing very intensive full-time work. If you look at the younger age groups, though, I mean, this is really quite stunning. I think you would be hard-pressed to find any profession where 90% of the people educated in that profession are working in it. And if you look at the numbers of people who let their licenses lapse, in these younger age groups, it is very, very few. Most people who, once they obtain a nursing license, they keep it, and most of them are working in nursing. And I define nursing very broadly. So they could be the chief nursing officer, they could be a nurse informaticist, they could be doing a lot of different things in nursing, but the vast majority of them, almost all of them, are working in nursing. But you can also see in this, if you start looking a little more closely, some interesting impacts that came from the recession of 2008. So when that recession hit, our survey went into the field early in 2008, and then the stock market crash was later in 2008. So I think 2008 was kind of just a little bit before the economy really melted down. 2010 was kind of the bottom. So if you look at the data, so the 2010 line is the solid turquoise one, the third one over from the left. In 2012, is the greenish one next to it. So for older nurses, there was an increase in employment, not for the 65 ups, but for 60 to 64, for 55 to 59, for 50 to 54, there were increases in employment rates. I heard anecdotally from nursing HR people that basically if you were kind of thought that you were near retirement in 2008, 2009, 2010, you didn't retire because your retirement portfolio had just gone down the toilet with the stock market crash, right? Your spouse might have been laid off, so you don't know what's going to happen to their retirement savings, right? And so a lot of nurses did not retire. In fact, even maybe increase their hours of work in order to make up for their unemployed spouse's income loss. So we had that going on. What did that mean? Look what happens to the employment rates of this under 35 group. You can see the drops. So that was the new graduates can't get jobs. Now, I mean, for drops, right? You dropped from 97% employment to 91% employment, so you're still over 90% employment. But still, that was the first time we had ever seen the employment rate for younger nurses drop that low. And that was a cause for alarm. And that was exactly what was going on when people said we have a surplus of nurses and new grads can't get jobs. And since then, it's recovered. So, I kept promising I'd show you a chart of numbers of graduations per year. So that recession hit just as we were peaking our numbers of graduations. After all the work that the deans and directors did to grow our nursing education programs to deal with the shortage, all those new graduates are hitting the market just as the market softens up on them. And there you go. You kind of have the perfect storm for creating a perception of a surplus. So we also have looked at some data about average income from nursing jobs. And this is from the latest survey of California nurses that's been published, although the chart in the report doesn't have the recessions marked on it. But if you look at the periods of time when there were recessions or there was a perceived surplus of nurses, you can see that wages flatten out, right? There isn't wage growth. And then when there's a perception that the labor market is really strong, you can see the wage growth. The red line is inflation adjusted to all be in 2016 dollars, and the yellow line is just the nominal wage growth. So during that 2008 to 2010 period, wages just completely flattened out, as they had in the prior surplus period. But now we're back on a trajectory of some slow growth, and we'll see what happens as we move along. So to get a little more information on this, one survey that we've been doing has been of chief nursing officers in California, and we've been doing these now for about 8 years. And about half of the CNOs in California will respond. We ask them a whole bunch of questions, and then we also share data with the Hospital Association of Southern California because they do a vacancy and turnover survey. So one of the questions we ask is, what is your perception of the labor market? Do you think there's high demand, moderate demand? The demand is in balance with supply, which would be the yellow. And then the blues are perceptions that there's a surplus. So you can see at the bottom of the recession, 2010, that more than half of hospitals are perceiving a surplus, and relatively few are perceiving that there's a shortage. And now we've moved to a mode where almost all the CNOs are saying that they perceive a shortage of nurses. And there are regional differences in this. I'm not going to spend we could spend a lot of time on this chart, but we don't have that much time. But if you look at it, there are some regional differences. In general, I would say that the southern border one, the San Diego and Imperial counties, they have a pretty tightly calibrated labor market. They don't have a lot of people moving in and out of it. So they have a lot more concern about what's going on with shortages there. Inland Empire tends to report shortages. Central California, I'm going to show you more data on them. I worry about Central California. Okay, so then in 2013, we decided to start saying, okay, overall, what do you think the labor market is? Now, what do you think it is for nurses with experience? Right? So these would be nurses where you're trying to put them higher for care management, intensive care, the operating room, labor and delivery, right? You got a specialized department, specialized set of skills you have in mind for an experienced nurse. And now, so we converted that thing you just saw into 5 points, a 5 being shortage and a 1 being surplus. And you can see that the averages across all of these years are basically very, very strongly towards a shortage of experienced nurses. And we asked what areas do you have the most problems, and it was emergency department, labor and delivery, operating room, intensive care. Those kind of show up year after year as the areas with the biggest shortage and recruiting problems. Okay, what about new graduates? Anybody want to guess? Whoa, right, almost the opposite. And at the bottom of the recession, these lower bars for each of these, it was like, oh yeah, we have a shortage of experienced nurses, but we don't want the new grads. There are way too many new graduates. Now we're starting to see this balancing. 3 would be a balanced labor market. We're starting to see in some of the markets it moving towards a balanced labor market for new graduates. But what is going on with this? So you can't find experienced nurses. You don't want to hire the new graduates because you think that the new graduates are somehow going to get experience from the fairy that comes down from the sky and gives them experience when you didn't hire them, right? So somebody needs to hire them so they get experience. There is kind of a problem there. There are some differences between rural and urban. In general, rural hospitals are more likely to report shortages. They tended to report shortages through the recession, whereas not as much the urban hospitals, but now rural and urban are pretty much on par with each other. Vacancy data reflect exactly these same patterns. These are from the Hospital Association survey, and the vacancy rates have gone up as the economy has recovered. And the Health Impact, which is a state nonprofit that focuses on nursing's role in improving healthcare in California, also has been showing at the bottom of the recession, they were finding in a survey that they did about half of nurses, 6 months to a year out, said they hadn't found a job yet. And now it's, nearly all of them have a job. They basically survey everybody who's graduated, or half of the people who graduated in the prior year. So some of them have been out for 1 month, and some of them have been out for 12 months. So there's a lot of variation in how long people have been out of their nursing education programs. But you can see the employment rates growing there. So it's very consistent. And let's see, from their survey, you can also see that there are some regional differences. New graduate employment rates highest in the Central Valley, pretty high in the Central Coast, which are the areas where we think we have the greatest shortage issues. And then percent of hires that were new graduates has gone up a little bit in our most recent survey, or in the most recent Hospital Association data, but it's been pretty stable that about 1/3 of new hires tend to be new graduates. And international recruitment, we're all puzzled about this because it dropped to almost 0 during the recession, went up a little bit, and then the data show this spike here, but each year different hospitals respond. Because anecdotally, this is not, we do not hear about this much growth in international recruitment. So we think that this just might be whichever random hospitals happen to respond this year were the ones that happen to be doing more recruitment. We'll see what next year's data look like. So I'm going to do a quick lesson in labor economics about how I interpret these data from what's happening in our labor market. So the supply of nurses really comes down to how many nurses you have licensed, and that's impacted by the flow in of your graduations and interstate migration. We recruit from other states, and people like to move to California, and also our flow out of California. So some people move away, some people retire, some people die. From my data set, they basically lose their license, right? Their license lapses for some reason. I don't really care why. If you're not licensed, you're out of my data now. And then you've got decisions to work. So once you do have a license, you decide whether you're going to work. And economists would say you're making a trade-off between what are the benefits of working versus what are the costs to you of working, right? You're spending more time earning money. That's good. You're spending maybe less time doing childcare or doing other things you might like to do, your hobbies, whatever interests, and that might be bad. And you're making a decision about how much to work, weighing those against each other. That'll get affected by what the wages are. Your family situation, the burnout, stress, schedules of the jobs, like how good is the job, how bad is the job. If you have a great manager, the hours might be long and stressful, but you might love your job because your manager is so supportive. You might have a great, easy job, but your manager is kind of obnoxious, and therefore you might hate your job, right? So there are a lot of different attributes that make jobs good and bad. So the normal model that an economist would use would say that as the wages go up, the supply of nurses will go up. So if this is wage, this is number of nurses. If you have a higher wage, your supply is higher than if you have a lower wage. And in California, wages are higher than in other states. So California is a very attractive place to work for nursing. Now, the demand side of the market, well, what affects demand for nurses? Demand for patient care, right? Fundamentally, if patients need care, then we need nurses. And that gets affected by your population demographics, community health status, healthcare financing, who has insurance, who doesn't have insurance, and then the cost of other healthcare inputs. And what I mean by that is if registered nurses are super expensive, there might be an incentive to see if you can deliver the care using some other configuration of workers and of professionals. And so the notion there would be if wages are high, you demand fewer nurses, and if wages are low, you want more nurses. So if you put them all together, this is where economists get all geeked out and excited. If you put them together, the notion would be that wages should adjust to make your labor market balance. So if you have a surplus, meaning that your supply is greater than your demand, that would mean your wage is too high. Now, what happens in that case is rarely do employers say, we're going to cut everybody's wages 20%. They don't do that. They let inflation eat away at your wages, which is what we saw on the chart of inflation-adjusted wages, right? We just saw it stagnate. If the wage is too low and demand is greater than supply, then what happens? Hospitals and other employers all start competing with each other. And when they compete with each other, then the wages tend to go up. So in a perfectly competitive market, you'd have no shortage. Now, in truth, we don't have perfectly competitive markets. We have limited numbers of employers for nurses and in healthcare. If hospitals are the dominant employer, and some communities only have one hospital. There could be delays in wage changes just due to overall budgetary decision processes that organizations have. You've got various regulations that include that nurses are a licensed profession, and it takes anywhere from 3 to 5 years to go from ground zero to being a licensed nurse. You've got minimum staffing requirements, which were established in 2004 as a patient safety regulation in California so that hospitals cannot reduce their staffing below a certain level. And you've also got this argument of what we call backward bending labor supply. And the theory of that would be that rather than wage increases uniformly making you decide to work more hours, at some point the wages might get so high that you can say, oh, you just raised my wage again? Wow, I can pay my mortgage now if I work 3 hours less. I think I'm going to work less this year, right? And so that would be kind of the counterintuitive of essentially in that upwards line, it kind of goes backward at some point because then you can start taking advantage of some leisure. So that's that chart. I'm kind of skipping ahead to some things. So what can we learn about from forecasting? And there are various forecasts that people do based on these economic principles to try to say what's going to happen in the future. So there's some national forecasts, and the national forecasts say nationally the labor market for nurses is balanced through 2030. In fact, there might even be a little bit of a surplus by then. There's this great guy who's in Massachusetts, David Auerbach, who's a friend and whose work I like a lot, and they project a tiny shortage. So this is nationally 128,000 RN shortage that they're projecting. And then for California, we've got multiple different sources. The national federal forecasts project that California is going to be a little bit short. My own forecasts say not really. And so I'm going to skip some of the technicals because I have 5 minutes? Really? Ooh, okay, maybe I won't get too technical. Basically, this is what I described, where you've got a number of nurses that are licensed, and you have an inflow and an outflow. And then you've got people make decisions about how much to work, and that's essentially the supply model. It's a giant Excel spreadsheet. There are fancier models you could do, but this Excel spreadsheet's easy to update, so we just update it really frequently. rather than try to do something big and onerous that takes forever to update, and then we don't have the most frequent data in it. Forecasting demand, though, is really hard, quite frankly, because it's not really clear what number of nurses we should have. We know how many are employed right now, but if there's a shortage, maybe we need more. Okay, but then how much demand there is also determined by how our healthcare system is financed. If you wanted to talk about how many nurses you need for optimal health, that might be a different number than the number that you would need based on the current financing system. So it's very fuzzy about what number of nurses would be ideal. And you know, another challenge in that is that because nurses are like the stem cell, it's almost like no matter how many nurses you put out into the system, they will get employed, right? They will get hired somewhere because they are so useful in so many different kinds of care settings, but the wages might not grow as much, right? You might have different kinds of dynamics going on that might also be detrimental for nursing. So you can do different things. You can try to pick, like for California for years, we've said, boy, it would be nice if we were not ranked number 46 in the country in employed nurses per population. How about if we tried to be number 37th, like the 25th percentile, instead of like the down at the bottom, like the 4th percentile or wherever we are. Or what if we tried to hit the national average? Or what if we wanted to deliver the same number of patient days per age group as we do now in hospitals? How much growth do we need to attain that? And then you can also do much more sophisticated models like the federal government has been doing. And there is a tool that I need to use to see how those calibrate against what my more simple approaches produce. But typically these models, it's worth noting, they assume that wages don't change, that there are not going to be changes in graduations, or if there are, they're going to be very predictable changes in all of the different parameters, which is why we update ours frequently, because all of these things do change. So the first thing to note is that we project graduations to hold steady, and this is based on the California Board of Registered Nursing's annual school survey. One of the questions in the survey is how many new enrollments do you expect to have next year and the year after? And so we use those data to project then how many graduations that there will be subsequent to those new enrollments. And so we project over time, we're going to be holding pretty steady between 10,500 and 11,500 graduates per year, which is a really good rate. So when we put together all the supply forecasts, of course, I'm an economist, so I'm going to hedge my bets and say on one hand this, and on the other hand we could get that. But basically, let's see, the one that I call the best, which is kind of if you take the average of all the different parameters, you get this blue line of a nicely growing supply in California. If you, in 2015, we had the slightly lower numbers, so some of these parameters look a little bit better for 2017 data. Let's see, the federal dot disappeared. It's dark blue and it matches the background. Sorry. Oh no, it's this one. This is the federal forecast of supply. I don't know why theirs is so much higher than mine. I need to figure that out. But I think it all comes down to different parameters. My understanding is that their forecasts assume that more newly licensed nurses will actually work in California instead of move to another state. I think that that's one of the key factors. And they assume lower retirement rates than what my data show. And then this is our worst case scenario. What if our nursing schools actually shrunk a little bit and a lot of our nurses decide to leave California because the traffic and the cost of living is too much? And so that's our worst case scenario. So we could throw ourselves into a shortage, right? We could throw ourselves into a bad situation. Right now, the data are showing probably not. And I'll be updating this soon because the new school survey data has come out. Okay, what about the demand side? So I've got three different demand lines on here. They're all the red lines. These two are just based on population ratios. So trying to achieve the national 25th percentile and the national average. And this line that's more steeply sloped is based on using OSHPD data and saying, what if we wanted to try to produce the same number of patient days per age group of patients in the future? So it accounts for the aging of our population. And it also assumes that today we're employing the correct amount, which might not be true. But if you make that assumption, our supply is pretty much a little ahead of where demand is, and we are shooting at that national 25th percentile. Now, we might have a little bit of a problem here, but you notice overall, employers in California think there's a surplus of new graduates and a shortage of experienced nurses, so I think maybe these things are remediable. But this is an area where there might be a little bit of room for concern. I think we're in good shape, but I think we need to keep an eye on it. We just did some forecasts for the San Joaquin Valley. UC Office of the President supported this analysis. And we hope to do analyses for the rest of the different regions of California. But for the San Joaquin Valley of California, these are our supply lines. The solid line is the baseline, and the dashed line is the worst case scenario. The Central Valley is not going to maintain, they're going to have a declining nurse population unless a lot more nurses start migrating to the San Joaquin Valley or they start growing their nursing education programs a lot. So we know that we have really big regional differences. So while overall I look at this chart and I say I'm not so worried about California as a whole, but boy, I am worried about some regions of California. And that is the maldistribution that Stacy commented on, that we need to be paying attention to this maldistribution of nurses. We have too many in some regions where they're not finding jobs, and we have not enough in other regions. And how do we deal with this? And that is easier said than done. So, we spend all this time working on our analysis, and then you have like 1 or 2 charts at the end, and look, there's my data. That's kind of the life of a researcher. So this is a summary slide, so I'm going to skip that one. I think we have concern that if supply drops, if our nursing education programs shrink, or that we have nurses leave California, we're in trouble. And we also could have more retirements. Maybe the baby boomers are going to retire faster than we expect. That could be a problem. And we also have rising demand for services, and we don't know how that's going to continue to change. So we could get a new shortage. And that is expensive. It results in patient care lapses. It results in productivity losses. It results in overtime pay, the cost of international recruitment. And so we really don't want this to happen. And I'm going to skip all the policy strategies because he's given me the time's up. But you can ask questions about those. And I do believe that the PowerPoints will be distributed and shared on the Sacramento Center website, too. So you can get all of those. And we do have these websites that you can go look at if you want all the glorious data. So there we go. Questions?